Imagine trying to patch a leaky pipe in your house, like a pipe under your sink. But this pipe isn't made of copper or PVC. It's made of living tissue.
Yeah, and it's a highly pressurized environment.
Exactly. It's
Yeah.
highly pressurized, and the second you pull your wrench away, the water just shoots right back out at you.
Which is completely different from how we handle leaks in the mechanical world.
Oh, totally. Like if you have a leak in your car's AC system or, you need to stop fluid from backing up in a drain, it's incredibly straightforward. You just jump online, you buy a piece of hardware, and the problem is solved.
Right, you just buy a valve.
Yeah. I was literally just looking at a listing on eBay earlier for this. It was called wait, let me remember, a one-piece filler backflow fitting, I think, for a car's AC conversion. You literally just screw it on, and the laws of fluid mechanics are officially contained.
Because the fluid goes in and it physically cannot come out.
Simple. But the human body, however, does not come with threaded valves.
No, it definitely does not. When you puncture human tissue, you don't get the luxury of screwing on a threaded cap to keep the liquid where it belongs. You are relying entirely on, well, invisible physics, I guess. Physics, fluid dynamics, and anatomical manipulation.
Because the body actively fights back.
Exactly. The body is this dynamic, pressurized environment that actively wants to reject whatever you just put into it.
Which brings us to our topic today. Welcome to today's deep dive, everyone. We are looking at a really fascinating stack of clinical literature, nursing guidelines, and even a few mechanical manuals to answer one highly specific but surprisingly complex medical question.
And it's a question most people never even think about until they're sitting in the chair.
Right. The question is, how does the clinician prevent filler reflux out of the needle tract immediately following withdrawal?
Because it wants to leak. It wants to come right back out.
It does. And whether you're getting a cosmetic filler or, an eye injection, a GLP-1 weight loss shot, or just a deep muscle medication, there's this hidden world of physics happening right under your skin. What looks to you and me like a simple poke and push is actually this highly choreographed maneuver.
It's a maneuver to fight back against the body's natural hydrostatic pressure.
So let's start with the basics of what's actually happening under the surface. When a needle goes in, it doesn't just cleanly separate the tissue and seal perfectly behind itself, does it?
Not at all. It's basically carving out a temporary exit route. It creates what we call a potential space, which is essentially a microscopic tunnel.
A tunnel for the fluid to escape.
Exactly. And we actually have ultrasound studies that visualize this filler behavior in real time. The measurements are pretty wild. When a clinician uses a sharp needle, it creates a space that is approximately 33% larger than the needle's own diameter.
Wow, okay, so it's already creating a gap.
Right. But it gets crazier. When they use a blunt cannula, which is a tool with a rounded tip instead of a sharp one, it creates a space nearly double its diameter.
Wait. This doesn't make sense to me based on what I always hear about aesthetic medicine.
I know so.
Well, if a blunt cannula creates this massive gaping tunnel almost twice its size, why are they considered the gold standard? Like, I constantly see them praised for being the safer option for cosmetic fillers.
Oh, they are definitely safer, but specifically when it comes to the vascular system.
Meaning blood vessels.
Yes. Because the tip is rounded, it tends to push blood vessels aside rather than slicing right through them like a sharp needle would. That's critical for preventing catastrophic complications.
Right, vascular occlusion.
Exactly. Which can lead to tissue necrosis or, even blindness in extreme cases. But that vascular safety comes at a major mechanical cost. It leaves a huge wake behind it.
Okay, so how does that massive backflow actually play out when you're trying to inject something thick and heavy? Like if you're trying to put a dermal filler in a very specific spot, doesn't that giant tunnel just, ruin the placement?
Yeah, absolutely can. Let's look at a specific clinical example from the source's chin projection.
Oh, this is a good one.
Yeah, so clinicians will often take a heavy, highly viscous hyaluronic acid filler and inject it deep down right onto the chin bone, the periosteum.
Thus, they want to build the chin out, right?
Right. The goal is to project the chin forward. And the working theory for a long time was that this thick, heavy gel will just sit there like an anchor on the bone.
Makes sense intuitively.
It does, but high-resolution ultrasound imaging completely debunks that. Because of that large cannula tract we just talked about, the filler doesn't actually stay put. It gets squeezed by the natural tissue pressure and travels right back up that pathway.
Oh, man, so it just slides right back up the tunnel.
It redistributes superficially. It follows the fibrous bands under the skin, pooling up into the mentalis muscle and the subcutaneous fat.
So instead of pushing the chin outward from the bone to project it forward like they wanted, the filler just leaks up closer to the skin and widens the chin horizontally?
Exactly. It completely sabotages the aesthetic goal. You end up with a wider chin instead of a projected one.
Because the fluid is just obeying the laws of physics.
Right. It's taking the path of least resistance rather than following the clinician's actual intention.
That is wild. Okay, so if this tunnel acts like a fluid highway with no speed limit, how do clinicians actually stop the traffic? I mean, we know we can't use an eBay conversion valve, so what is the first tool in the clinical toolkit to actually prevent that filler reflux out of the needle tract immediately following withdrawal?
Well, if you can't plug the hole, you have to manipulate the architecture of the tunnel itself.
Okay, manipulating the architecture.
How? One of the most intense but clearly researched examples of this comes from ophthalmology. We're talking about intravitreal injections.
Which means injections directly into the eye, right?
Yes, directly into the eyeball.
Oh, wow. That is an intense visual. Just the thought of an injection in the eye is a lot for me, but walk us through the mechanics there. How does changing the architecture of the tunnel keep the fluid inside the eye?
So when a clinician uses a straight perpendicular plunge, meaning a direct 90-degree angle into the eye fluid reflux, occurs in just over half of all patients.
Over half.
Yeah, 51.4%. The medication, or even the natural vitreous fluid of the eye itself, just leaks right back out of the hole.
That's terrifying.
It's not ideal.
Hmm.
But researchers found they could drastically drop that failure rate to roughly 17% by using what's called the double plane tunnel technique.
A double plane tunnel, what does that look like?
Instead of going straight down, the clinician enters at a shallow 30 to 45-degree angle. They tunnel through the sclera, which is the tough white part of the eye, for a short distance, and then they redirect the needle downward to 90 degrees to enter the center.
Okay, I think that makes sense. It's like building a switchback road on a steep mountain.
That's a great way to picture it.
Right, because a straight road means a runaway truck, or in this case, pressurized fluid, is just going to barrel right back down and escape. But if you build a hard corner into the road, the fluid can't build the momentum to travel back up around that physical bend. The overlapping layers of tissue basically pinch the tract shut.
Exactly. And the physical geometry of the instrument is just as important as the angle of that switchback.
The needle itself matters that much.
Huge difference. Researchers actually used an experimental model with pig eyes and blue dye to track the exact path of the leakage.
Pig eyes and blue dye, got it.
And they tested all these different needle sizes. They found that a 30-gauge needle is essentially the Goldilocks size for minimizing drug reflux.
30 gauge?
Yeah, because thicker needles, like a 27-gauge, obviously left a bigger hole, which caused more leakage.
Right, bigger hole, more leakage. But I assume going even thinner, like maybe down to a 32 gauge, would be even better, right? Because a smaller needle should mean a smaller tunnel and less leakage.
You would think so, right? But the data actually showed the exact opposite.
Really? How is a smaller needle worse?
The 32-gauge needle is so thin and flexible that it creates a completely different problem. It allows for more vitreous incarceration.
Vitreous incarceration? Meaning what, exactly?
Meaning the jelly-like substance inside the eye gets dragged back into that tiny needle tract.
Oh, gross.
Yeah, the needle is so fine, it doesn't create a clean enough path, so it pulls the internal tissue into the exit route when it's withdrawn.
That sounds awful.
So to effectively stop backflow, you need the perfect 30-gauge needle, a deep placement, and that double plane switchback angle. You combine those, and you've basically engineered a biological one-way valve out of the eye's own anatomy.
It's just wild how much invisible geometry goes into a procedure that takes, what, maybe 2 seconds?
Pretty much, yeah. And we actually see this principle of manipulating anatomy elsewhere, too. The sources detailed a really similar tunneling technique used by urologists.
Oh, right, for the condition where urine flows backwards, right?
Yes, vesicuratal reflux. Basically, urine flowing from the bladder back up into the kidneys. To fix this without major surgery, they use what's called the double HIT technique.
Double HIT.
They inject a bulking agent like a polyalcohol copolymer right under the lining of the ureteral tube where it meets the bladder.
Okay, so they're injecting under the lining.
Right. The first injection pinches the tissue together further up the tube, and then the second injection creates a physical mound right at the opening.
So they are literally physically injecting a biological speed bump to prevent the fluid from traveling the wrong way.
Exactly. They alter the landscape to control the flow.
That is so cool. But changing angles and building speed bumps works beautifully for the eye or the bladder where you have, some maneuvering room. But what happens when you don't?
What do you mean?
Like deep intramuscular injections, vaccines, or heavy medications, where a straight 90-degree plunge deep into the muscle is absolutely mandatory. You can't do a shallow switch back there, right?
No, you definitely cannot. You have to find a way to break the straight line without changing the angle of the needle.
Which sounds impossible.
It does, but this brings us to a really clever nursing technique called the Z-track method.
The Z-track method. I've heard of this.
It's designed specifically for deep intramuscular injections where a straight angle is required, but leaking is completely unacceptable. It's especially critical for medications that are highly irritating or staining.
Staining, like it changes the color of your skin.
Yes. A perfect example is iron dextrin. If iron dextrin leaks out of the deep muscle and tracks back up into the fat layer in the skin, it will cause permanent dark staining.
Permanent.
It literally tattoos the patient from the inside out.
Wow. Okay, so keeping that fluid locked in the muscle is crucial, not just for ensuring they get the full dose, but for preventing permanent cosmetic damage. So how do you create a physical seal if you're forced to inject straight down?
The secret actually happens before the needle even touches the skin.
Ah.
Yeah. The clinician takes their non-dominant hand and firmly pulls the patient's skin and the underlying fat about an inch laterally.
Like pulling it tight to the side.
Exactly. They pull it to the side and they hold it there under tension. They are intentionally displacing the superficial layers of tissue so they no longer line up with the deep muscle underneath.
Okay, I'm visualizing this.
And while holding that tension, they insert the needle straight down at 90 degrees, deep into the muscle, and inject the medication.
And then when they pull the needle out and let go of the skin, the top layers just snap back into their normal position.
They snap back, and that straight hole, the needle just cut through them. It shifts.
Because the layers moved back.
Right. The hole in the skin no longer lines up with the hole in the fat, which no longer lines up with the hole in the muscle. The continuous tract is physically broken.
It turns into a zigzag. The letter Z, hence the Z-track method. I see it now.
It's very elegant.
It's like shifting tectonic plates. The fault line was completely straight when they drilled down, but once they let go, the layers slide back, and now the tunnel in the muscle just hits a solid ceiling of fat. The fluid is physically trapped deep underground.
It completely seals the medication in the muscle, where there are fewer nerve endings and better blood supply for absorption. And studies show this method actually reduces bruising and is significantly less painful for the patient than standard intramuscular injections.
Wait, it hurts less?
Yes. The lingering pain you feel after a shot is often caused by the medication irritating the subcutaneous fat on its way back up to the surface. By trapping it down deep, you eliminate that irritation entirely.
That makes total sense. So we have
Yeah.
the switchback angle for the eye, we have the tectonic plate shift of the Z-track for the muscle. But reading through the clinical guidelines for GLP-1 weight loss shots, I realized all these physical maneuvers mean nothing if the clinician rushes the withdrawal.
Absolutely true. Mechanical techniques only work if you respect the hydrostatic pressure of the body.
Which brings us to the 10-second rule.
Yes, the 10-second rule. Once the plunger is pushed all the way down, the clinician cannot just pull the needle out and move on to the next patient.
They have to wait.
They have to freeze. They must hold the needle perfectly still inside the tissue for a minimum of 5 to 10 seconds before withdrawing.
10 seconds of just sitting there with a needle in your arm, that must feel like an eternity. What is actually happening during that pause?
You are allowing the localized pressure to equalize.
Equalize how?
Well, by pushing fluid into a confined space, you drastically spike the pressure at the very tip of that needle. If you withdraw immediately, that high-pressure pocket of fluid is going to forcefully follow the vacuum of the retreating needle right back out of the skin.
Oh, it acts like a vacuum.
Yes.
Yeah.
Waiting 10 seconds allows the medication to begin dispersing into the microscopic tissue spaces. The pressure normalizes.
So you avoid that high-pressure geyser effect?
Exactly. And the actual withdrawal has to be incredibly disciplined, too. You have to withdraw smoothly at the exact same angle you inserted.
Meaning, if you entered at 90 degrees, you exit at 90 degrees.
Right. If a clinician carelessly changes the angle of their wrist on the way out, the sharp tip of the needle acts like a tiny scalpel. It slices the internal tissue, widens the tract, and destroys the very seal they were trying to create, actively encouraging leakage.
Okay, this brings up a very relatable scenario because I am totally guilty of this.
Oh, no. What do you do?
After I get a shot, especially a painful one, My immediate instinct is to rub my arm. Like, I massage the area thinking it'll soothe the pain or, help the medicine spread out. I'm guessing, based on all this fluid dynamics talk, that's a terrible idea.
It is one of the absolute worst things you can do.
Oh, man.
You should never massage a Z-tract injection
Mm.
or an area that's prone to filler backflow. Think about the physics of what you're doing. By massaging the tissue, you are acting as an external pump.
Right, I'm pushing on it.
You are physically squeezing the tissue, creating external pressure that forces that trapped pocket of fluid right back up the tract the clinician just carefully sealed.
So by rubbing it to make it feel better, I'm literally squeezing the medication out of my muscle and back into the fat layer where it's going to hurt more.
Exactly.
Hmm?
You are actively undoing the Z-tract or the switchback angle. The proper protocol is to just apply gentle, static pressure with a dry cotton ball.
Just hold it there.
No circular motions, no deep tissue massage, just hold it still.
Good to know.
Mm-hmm.
Okay, let's talk about what happens when a clinician doesn't respect that pressure. What if they ignore the back pressure of the tissue, they don't wait the 10 seconds, or they try to force a really thick dermal filler in way too quickly? Does the body just push it out the skin?
It can actually be much more dramatic than just leaking onto the skin.
Yeah.
The fluid will always take the path of least resistance, right? If a clinician forces a high-viscosity injection too quickly against the natural back pressure of the tissue, that path of least resistance might not be back up the patient's skin tract.
Where else could it go?
It can go backward into the equipment itself. The back pressure can literally cause the syringe hub, which is the connection point where the needle attaches to the plastic syringe, to explode or leak right in the practitioner's hand.
Wait, the syringe explodes just from the pressure of human tissue fighting back?
It pops right off or ruptures. The sources actually provide specific advice for injectors on how to handle this gracefully.
How do you gracefully handle an exploding syringe?
They recommend stopping the treatment calmly, replacing the syringe, and explaining to the patient that there was a small pressure issue causing product leakage at the hub.
Small pressure issue. That's good PR.
It really is. But it highlights how much raw physical pressure is fighting against the clinician during these procedures. The body is a closed system that fiercely protects itself, and it will push back with enough force to literally break plastic.
That is just incredible. Let's summarize this invisible mechanics happening during a simple injection. We started this deep dive looking for a mechanical valve to stop a leak. What we found is that the human body requires absolute geometric mastery.
Geometry and patience.
Right. To prevent filler reflux out of the needle tract immediately following withdrawal, clinicians are relying on switchback angles in the eye, zigzagging Z-tracts in the deep muscles, the exact physics of a 30-gauge needle, and the sheer discipline of a 10-second pause just to let the pressure equalize. Every single millimeter of depth, every degree of the angle, and every second of time alters the physical outcome of the medication.
It really is a beautiful convergence of human anatomy and fluid dynamics.
Yeah.
We often think of medicine purely in terms of chemistry, what the drug does once it's inside. But getting it inside and keeping it there is purely structural engineering.
It is. So the next time you or someone you know gets a vaccine, a cosmetic filler, or a medical injection, pay close attention. Watch the clinician's hands. If they pull your skin tightly to the side before inserting the needle, or if they make you hold perfectly still for 10 long seconds after the plunge, you'll know exactly why. You're not just getting a shot, you're witnessing advanced fluid dynamics and anatomical engineering in action.
It certainly changes how you view a simple trip to the clinic. And, it raises a fascinating question for the future.
Oh, like what?
What if the future of injectables isn't about the clinician's physical needle technique at all?
What else would it be?
Imagine if we developed smart fluids.
Smart fluid.
A medication or cosmetic filler that is chemically formulated to instantly thicken or gel in response to body heat. The split second it leaves the needle.
Oh, wow.
A fluid that dynamically changes its viscosity the moment it hits 98.6 degrees. It would make backflow physically impossible, building its own internal one-way valve instantly without needing any switchback angles or Z-tracts. Something to think about.
That would entirely change the game. We'd finally have our biological eBay conversion fitting. Well, until those smart fluids hit the market, we will leave the geometry to the pros. Keep questioning the things that seem simple, because underneath, there's always a hidden world of mechanics waiting to be unpacked.